Hey everyone, my name is Daniel. I am a fourth year medical student and I'm the co-founder of USMLE Forum of Pakistan. Welcome to our second episode of Neurology High Yield podcast. I hope you have watched the previous video as well, and this video is a sequel of our previous video. Awesome. Now in this video, I'm going to give you some clinical clues regarding some basic neurology pathologies that are frequently encountered by students in the NBMEs, right? And these questions and these pathologies are taken and from the NBMEs exam, right? So high yield, these are very high yield things and to discuss, and these are very beneficial for those students who are preparing for a step 1 exam, and also for those students who are not preparing for a step 1 exam but they want to reinforce their concepts regarding some neurology pathologies. Awesome. Okay, so first of all, hemisection of a spinal cord, ipsilateral loss of proprioception and motor function, contralateral loss of pain and temperature. What's your diagnosis? Great. Brown-Sequard syndrome. In Brown-Sequard syndrome, you have hemisection of a spinal cord, yeah, and to understand the concept of Brown-Sequard syndrome, you have to know about you should have a background of the decussation thing of spinal tracts. So let me explain you that thing in just few minutes. So first of all, let me tell you that why these things occur. You know very well that the pathway which is responsible for the pain and temperature is the spinothalamic pathway, anterolateral spinothalamic pathway. So that pathway, if you remember back from your second year neurology module, that pathway decussate at the level of a spinal cord. So here you go. That's your spinothalamic pathway, and now it is decussating at lateral. It is lateral spinothalamic pathway, and now it is decussating at the level of a spinal cord. Awesome, right? Now, if and I am giving you a basic principle of neurology. Any pathway that decussate at the level of a spinal cord leads to loss of its concerning thing on the contralateral side. So what's the concerning thing for the spinothalamic pathway? Pain and temperature, right? So since it decussates at the level of spinal cord, so and in Brown-Sequard syndrome, of course we have a dysfunction or pathology at the level of spinal cord. So that's why it leads to loss of pain and temperature at the contralateral side, right? Hope I'm clear to you all. If I'm not, so you can contact and comment down below. Awesome. Now, secondly, the ipsilateral, why there is ipsilateral loss of proprioception and why there is ipsilateral loss of motor function. Let me tell you this thing as well. If you know that the proprioception thing is carried by dorsal column pathway, right? And the dorsal column pathway is decussates at the level of brainstem, right? So that's why as I've told you, that anything that decussate at the level of brainstem or in the upper brain, right, that leads to loss of the concerning symptoms at the ipsilateral side if the damage is at the spinal cord, right? Listen to me, if the damage is at the level of spinal cord. Awesome. So and you know that if the dorsal column pathway decussates at the level of a spinal cord, they are not decussating at the level of brainstem. They are not decussating at the level of a spinal cord. That's why there is ipsilateral loss of proprioception, right? Same goes for motor pathway. Motor pathway also decussates at the level of brain, not at the level of a spinal cord. So that's why any damage or anything you do to your motor pathway at the level of a spinal cord, it always leads to the loss of the concerning symptoms or concerning things at the ipsilateral side. So that's it about Brown-Sequard syndrome. But I would strongly suggest to see the CT scan or MRI of the Brown-Sequard syndrome. It's very high yield and frequently asked in the exam. Awesome. Secondly, now let's talk about another thing. So The patient is alcoholic, and he or she, mostly the females are dedicated to vegetarian diet. So first of all, you got a patient, she is alcoholic or she is committed to vegetarian diet. She complains, she got a complaint of paresthesia, ataxia. On the neurological examination, you got positive Bromberg sign, and you also got hyperreflexia with spasticity. What's your diagnosis? Yes, it's subacute combined degeneration, and it's always due to the deficiency of vitamin B12, right? So those patients who are alcoholic, they may have vitamin B12 deficiency. Those patients who have some pathology or chronic malabsorption of vitamin B12, like patients having pernicious anemia, like patients having gastritis, like patients having pancreatitis. You know, pancreatitis can also lead to vitamin B12 deficiency. So those patients suffer vitamin B12 deficiency, loss of vitamin B12. They can also be vitamin B12 deficient, and of course, patients who are committed to vegetarian diet, they can also have vitamin B12 deficiency, right? So yeah. So how does it manifest? It affects, of course, it affects dorsal column. Let me tell you, most of the time, it appears as loss of dorsal column. Most of the time, right? But certain times they also give some motor symptom as well. But the prominent symptoms on your exam is most likely the loss of dorsal column pathway. Awesome. So loss of it affects dorsal column, it affects lateral corticospinal tract. That's why it leads to yes, please. It leads to yes, spasticity. And again, both Brown-Sequard syndrome and subacute combined degeneration of spinal cord, they both are upper motor neuron lesion as far as your motor neuron findings are concerned. And it exists due to spinocerebellar pathway damage. But spinocerebellar pathway is not always damaged. In some cases, it is spared. In some cases. Again, let me tell you that the most prominent symptoms is loss of dorsal column. Most prominent symptom. Awesome. Now you got a young patient and young woman, like she's in 30s or 20s, right? That's the most common demographic, and she has pain in her eye. Awesome. On the neurological examination, on her eye examination, you also see that she has problem with the gaze, right? She has problem with the gaze. With the gaze. Gaze means the vision, right? I mean the movement of eye. Yeah, that's how as simple I can explain you. So she had also some problems in the movement of eyes, in the eye movement, like the right eye movement is not accompanied with the left eye movement, right? Something like that. And her symptom worsens with heat. Awesome. Also, she explained that she had these symptoms in the previous year as well, and this is the second flare of her symptom. Okay. So what's your diagnosis? I've given you multiple buzzwords regarding this thing. It's multiple sclerosis, most commonly in female, European female, those female who are living at the locations that are comparatively colder, right? So those women are most likely affected by multiple sclerosis, right? Another important thing regarding multiple sclerosis, let me tell you that first of all, let me tell you some basic things regarding that the most common symptom you're gonna see, okay, optic neuritis, as I've told you, pain in her eye. Second most thing you're gonna see, internuclear ophthalmoplegia, right? And as I've told you that she got some difficulties with the movement of her eyes. Second important thing that I've told you, third important thing, I guess, that symptoms worsen with heat. So that's the basic things regarding multiple sclerosis. But another important thing that you must always know as a good medical student, that to diagnose multiple sclerosis, you need DS and DT. Now, what is DS and DT? DS is disseminated in space, and DT is disseminated in time. So, as I've told you that this patient complained that she had a similar symptom years ago. So it means that she had symptoms in two different time with gap in two different times. So it means that disseminated in time, having symptoms in at two different time periods. Awesome. In two different time periods. Another important thing that it is disseminated in a space. Now, what is disseminated in space? When you will go do MRI or of these patients, what you will see that lesions are on multiple sides. Some lesions are active, and I guess they appear as white, and some lesions are not active. They were from previous player. They are not that visible. They are not that appreciable, but again, they are dull in appearance. So this is called disseminated in space. So that's the major criteria to diagnose multiple sclerosis. That's more kind of clinical stuff, but I think that it's gonna help you in somewhere in your life, right? So that's it about multiple sclerosis. Okay, these things I have explained in the previous podcast. Ascending muscle weakness after diarrhea, GI infection, areflexia, high CSF protein with normal WBC count. High CSF protein with normal WBC count. What's your diagnosis? Awesome. So it's Guillain-Barré syndrome, GBS. I'm gonna say GBS because I have some difficulties in pronouncing this thing correctly. Awesome. The name is too hard to pronounce. Awesome. So, anyways, so it's GBS. It's ascending motor neuron pathology, and it's due to autoimmune demyelination of nerves. What actually happened that the pathologists have explained regarding these things that this is due to some molecular mimicry, right? So molecular mimicry occurs, and that leads to I know that by this time of your medical stage, you know what this molecular mimicry means. It means that a pathogen enters into your body, and that pathogens share the same antigen and got this identical antigen of your body. Now your body reacts to that pathogen, but ultimately it leads to the production of antibodies against your body itself, right? So it's a very detailed discussion regarding molecular mimicry. If again, I'm not compelled to explain you that thing right now. So again, but let me tell you that it is some autoimmune neuropathy, and it is ascending in nature, and the patient most likely represent that after some GI or respiratory infection and having ascending muscular weakness. Having ascending motor weakness. That's a more correct term regarding that. Awesome. Now, patients come to you, a 45-year-old male patient, or you can make him 50, comes to you with ptosis, diplopia, diplopia, and muscle weakness that worsens with use and improves with rest. And on the CT scan, on the chest X-ray, you also see thymoma. You also see visible thymus. What's your diagnosis? Myasthenia gravis, of course. That's it. Because in the myasthenia gravis, first of all, let me tell you that myasthenia gravis is associated with thymoma, right? And also important thing regarding myasthenia gravis is that it worsens with use, and the weakness worsens with use, and again it's due to the antibodies against post acetylcholine receptors, right? So why it worsens with use, again it's a very long discussion, but I can sum up by saying that you got damage to post synaptic acetylcholine receptors. Now if you are using your muscles, the acetylcholine in the synaptic cleft will be depleted, right? So that leads to complete weakness, right? And that's how the weakness worsens with use, right? If you use your muscle, the acetylcholine will be depleted, and there will be no more acetylcholine to bound to the receptors. Of course, most of the receptors are gone, but there are a few receptors working. But now you have depleted the acetylcholine. Now, who gonna trigger the remaining receptors? First, you have destroyed the receptors. Now you don't have even acetylcholine, so that's why it worsens with use. Awesome. Now, a 35-year-old female comes to you with proximal muscle weakness that improves with use, and she got dry mouth, no reflexes, and she's a smoker. What's your diagnosis? Okay. What's your diagnosis, my friend? I guess you might have diagnosed it correctly that it is Lambert-Eaton syndrome. Lambert-Eaton syndrome. But let me tell you a few things regarding that quickly. First of all, Lambert-Eaton syndrome has most common association with small cell lung cancer. So, small cell lung cancer got many paraneoplastic phenomenon. So, most important and most common phenomenon that goes with small cell lung cancer is that it is SIADH, right? So that's why patient have dry mouth, right? And also the patient and again the most common demographic of small cell lung cancer carcinoma is smoking, right? So patient with smoking suffers small cell lung carcinoma. And again, as I've told you, that small cell lung carcinoma is associated with Lambert-Eaton syndrome because the small cell lung carcinoma leads to the production of autoantibodies against pre-synaptic calcium channels, and that leads to, again, that's a classic buzzword for your and that's the simplest explanation of the Lambert-Eaton syndrome. That's why the demographic is a smoker